pre-treatment assessment to post-treatment assessment. It includes also quantitative and qualitative analysis. The quantitative, it was assessed, the method of nutrition was assessed using the voice, the quality of life using the scroll call, and the self-perception saliva using the romp. We use also an instrumental evaluation using fees and food administration. To scale were adopted, the penetration aspiration scale and the yield pharyngeal residue severity and rating scale. The qualitative assessment included 2 open questions posed by the student at the end of each treatment session and also a 4-point rating scale. Okay, the protocol of treatment. As a device of device, we use the new Track My Plus Pro, and there were 2 main displays. We use the open display. You can see in the first figure the waveform line during activation, and the second one is a game. By contracting the submental muscle, participants move the plane and reach the stars. The treatment was designed according to the neuroplasticity principle. Here you can see all the swallowing tasks based on the principle. I want to mention that the treatment was intense, an hour a day, 5 days a week for 4 weeks. In addition, the design of the treatment was based using incremental swallowing task. In the first week, we proposed only dry swallowing. The second week, we add food. The third one, we increase the number of swallowing tasks. In the fourth one, all these exercises were presented randomly. And we carry out statistical and qualitative analysis. Here the results. Okay, first of all, the method of oral intake. So there was a significant difference after treatment using the foil of the method of oral intake, and these improvements were maintained at the follow-up assessment. The pharyngeal residue, it's important firstly to mention that 3 participants had medication during the first week, medication at the base time and the vallecula using fees, and during the first week of during the first 2 weeks of assessment, no medication were found at the post-treatment assessment. Only residue of saliva and cracker on the vallecula decreased significantly after treatment, and these improvements were maintained at 3 months follow-up assessment. You can see here the graph. Okay, and no significant difference were found using the PES, and also no significant difference were found using the romp, assessing the self-reporting saliva. The quality of life. Only the subpart of the quality of life associated with food selection show a really statistical improvement. No improvement were found for overall scores. No adverse events occurred during the treatment. 3 participants report fatigue. And also we look at the adherence. 2 participants decided to stop because the treatment was too intense. The remaining participants turned to the clinic for the treatment. Okay. Feedback from participants were grouped in this theme. First of all, benefit on swallowing, such as benefit on saliva and cough, or positive change in diet, benefit on related swallowing functions, such as in voice, attention, concentration, benefit on feedback, benefit on the use of SurfMG biofeedback, on the food use, on the challenge using also the software, unexpected benefit and adverse effect. Event. So briefly, we could discuss that the intervention guided by neuroplasticity and motor learning principle using SurfMG biofeedback was effective in improving swallowing function and in maintaining improvement at the 3 months follow-up assessment in this sample. The main result were the change of oral intake, the reduction of pharyngeal residue, but also unexpected changes such as feedback and attention and voice quality. We definitely should investigate this in a future study, as well as fatigue. There was some discrepancy between quantitative and qualitative assessment. We should definitely look at a future study. I want to thank and more than pleased to answer all your questions.
you, Dr. Patel. Now is the time to Q&A answer. Is there any question for her? No. So, can I ask one question? So, do you think the possible mechanism to reduce the pharyngeal residue of the saliva or solid food using the biofeedback?
Yes, I think so. I think that through PNG biofeedback will help people to focus on the task, increase the number of swallowing, which are more
okay, number of swallowing important. Okay, so I understand that there is a difference of the objective assessment of the VE and self-reporting, right?
Yeah, there was some different, qualitative and quantitative analysis.
Yeah, and the patient cannot fear the improvement of the swallowing or residue in the pharynx or saliva, right? How do you think that the difference of the result?
I think maybe in Parkinson's disease we need to have specific instrument to assess the saliva, because patient report, for example, to have reduced drooling. However, the questionnaire was not really specific, and we used the squall as well to investigate quality of life. Maybe it was too long for them for cognitive and attention deficits. So I think that maybe we need to have specific instrument assessment for investigate, for example, quality of life in Parkinson related to swallowing function.
Right. Okay. So we have the one Q&A. What was the reason you believe was the reason for the difference between the quantitative and qualitative results?
Yeah, I'm sorry, I didn't explain so much. Basically, we see that there was main difference in the quality of life. We have in the squall there were no differences, but patient reported to really increase the quality of life, return back to go to the restaurants, enjoy meal food time with with family members. So we were asking why we have seen these main differences, and also for drooling. The main difference was this one. People we haven't seen any results at the ROM saliva scale, but patient report to have not to reduce drooling, many where they were talking. So we think that qualitative analyses were more specific in the studies. Thank you.
Right. Okay, so now it's the time to move the next speaker. Thank you, Dr. Patel.
Thank you so much.
But unfortunately, the fifth speaker cannot come and participate in this on this web. So, Secretariat, could you start fifth speaker movie?
Hello, my name is Ayodele Shashawan, and thank you very much for having me today. I'm going to talk about the Parkinson's disease and dysphagia randomized controlled trial I was involved in. These are our conflicts of interest. And during the talk today, I'm going to start with a bit of background about Parkinson's disease and dysphagia, before moving on to talk about the methodology, the results, and finally the conclusions. So, a little bit of background. As I'm sure you all know, Parkinson's disease is a condition which is characterized by the deposition of alpha-synuclein containing Lewy bodies within dopaminergic regions of the brain. As the disease progresses, the Lewy body burden increases and there is a decline in neurological function. This coincides with increasing symptoms for patients. Parkinson's disease does not just cause limb signs and symptoms, it can also cause dysphagia. Dysphagia is quite common in Parkinson's disease, and it occurs in up to 82% of patients at some point along their illness journey. When it does occur, it can occur directly due to damage caused to cortical swallowing centers or other swallowing centers caused by the deposition of destructive Lewy bodies, or indirectly due to Lewy body mediated damage to non-motor areas of the brain, which have the effect of causing dysphagia. For example, it is known that Parkinson's disease can cause dementia, and it is also known that dementia can cause dysphagia. In terms of the management of dysphagia, at the moment is quite conservative, involving dietary modification, altering the consistency of foods or fluids, and the use of dopaminergic medications. Now, what we don't know is whether neurostimulation, so for example, the use of repetitive transcranial magnetic stimulation or pharyngeal electrical stimulation, RTMS or PES, can improve swallowing in Parkinson's disease associated dysphagia in a similar manner to the promising results that have been seen with the use of these techniques in post-stroke dysphagia. So, to address that gap, what we aimed to do in the study was to study the effects of 3 different neurostimulatory mechanisms or methods. We looked at low frequency RTMS, which is RTMS delivered at a frequency of 1 Hz, which over the pharyngeal motor cortical center is suppressive. High frequency RTMS, which is RTMS delivered over the pharyngeal motor cortical area at a frequency of 5 Hz, which studies have shown is excitatory, and pharyngeal electrical stimulation or PES, which is a peripheral excitatory mechanism or method. And all these techniques were studied in people with Parkinson's disease associated dysphagia. We had 3 main outcome measures. The first was penetration aspiration score obtained from video fluoroscopic or VFS recordings. The second was swallowing timing data, also obtained from VFS recordings. And the third was cortical activity, which was measured using single pulse transcranial magnetic stimulation or TMS, from which motor evoked potential amplitudes were obtained and used as surrogate measures for cortical activity. So participants were consented and then randomized into one of 3 groups: PES, 5 Hz RTMS, or 1 Hz RTMS. In each of these groups, participants had real or sham stimulation in a crossover manner, with each participant acting as their own controls. Baseline measures of both VFS and TMS recordings were made before an intervention was applied, and this would either be active or sham depending on the day. Repeat measurements of TMS for cortical activity or VFS for swallowing behavior were then obtained. All patients tolerated the interventions well, with no adverse events being reported. 12 participants were recruited and randomized accordingly. So 4 were allocated to the 1 Hz R2-MES group, 5 to the 5 Hz group, and 3 to the PES group. In terms of the key results, what we found was separation between the sham and active treatment arms for each intervention. As you can see over here for thin fluids, following sham stimulation, participants had higher or worse penetration aspiration scores than following real stimulation. This relationship held true for fluid of a paste consistency. With regards to swallowing timing data, there was also some separation, as can be seen in these graphs of pharyngeal reaction time. As you can see, following real or active stimulation, participants had better reaction times than following sham stimulation. The picture for the motor evoked potential or cortical activity data was more mixed, and we think was reflective of the small numbers in each group. However, you can see that some separation was beginning to emerge. When subjected to statistical analysis, and we used t-testing, some caution must be employed because of the small numbers per group. However, for the PAS group, no significant differences emerged, and for the motor evoked potential analysis, no significant differences emerged. However, with regards to swallowing timing, specifically with regards to the PES group, there was a difference which was significant between the active and sham groups for thin fluids, with a p-value of 0.045. In conclusion, unfortunately the study was hampered by the small numbers, particularly in each group. However, despite this, the interventions were very well tolerated, and there were hints within the data of separation and emerging significance. And it is our hope that with bigger studies in the future, the relationship or the effects of these interventions become clearer. And these are my references. Thank you very much.
Okay, so this should be the this quite preliminary data. So we hope data over many number of the patients. So now I'm going to close this session. So thank you very much.
already?